Okay, folks, it's about time to get this meeting started. Okay, we've got a meeting immediately after this one. It'll be in this same room. Um, Rules Committee meets at 3. And, well, not in this same room. Rules meets immediately following this meeting. So we've got 2 bills, or two proposed study committees to look at. The third one by Representative Hawkins, we're going to just create that study committee out of the House Insurance Committee. So we'll not be looking at that particular one. I'm going to ask Representative Bennett if she'll come to the podium and present House Resolution 590 to take a look at or create a House study committee on Georgia barriers to access to adequate health care. And I think if you read this, you will look at it's related to the acute onset of neuropsychiatric syndrome, or PANS, or there's another one called PANDAS as it relates to streptococcal infection. The floor is yours. Thank you.
Thank you, Mr. Chairman, and to members of this committee and those who have assembled. PANS and PANDAS is a syndrome or disorder that was brought to my attention some time ago. Being a pediatric physical therapist working with children with special needs for over 30 years, this condition compelled me to want to do something and to help the families of this disorder. PANDAS, or PANS, if it is acronym, as you mentioned, is the pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. And as you will hear from the families who have gathered here today, this disorder is not widely known about, but it can cause catastrophic injuries to families who find their children having this disorder. It is a disorder that comes after a child gets strepped, and it manifests itself in ways of mental disorders. What is known about it is that if the disorder is diagnosed early and treatment is started early, it can alleviate some long-term complications from this disease. And so it impacts about 20,000 kids in Georgia, but it has such a wide range of effects, not just on the children, but also on the families, on the school, on the communities, as well as on our healthcare system. And so we thought it would be great in the interest of Georgia if we would take a look at it, have a study committee, examine what the barriers are to having others to know about it, to awareness as well as to treatment, and to come to some conclusion as to how Georgia can become one of the forerunners in advancing in this disorder.
Okay. Are there any questions of the sponsor? Okay, very good. Here, nope, we got some people who want to testify. I see no questions. We'll ask the folks who are interested in speaking on this bill. They're all from the Southeastern Pandas Association. We have 5 who want to speak. So if you don't mind, you could limit your remarks to about 3 minutes, or unless you're going to speak for everybody. And your name is Jessica, how you pronounce it, Gowan? Some of y'all's handwriting is about as bad as mine. The floor is yours. Thank you.
Good afternoon. My name is Jessica Gowan. I'm the mother of 3 children diagnosed with PANDAS and a founding board member of the Southeastern Pans and Pandas Association, or SEPA. My goal in my testimony is to give a little bit of context for the information that the families will be talking about today. So I'll give you just a quick overview of disorders, their incidence, the barriers to care in Georgia, and the treatments and their costs. And then for simplicity's sake, I'll just be referring to PANS, Pediatric Acute Onset Neuropsychiatric Syndrome, as an umbrella term for both of the disorders, because PANS-PANDAS is kind of a mouthful. So in layperson's language, with these disorders, a child gets exposed to an infection, and instead of just having normal sick symptoms, they develop a new onset of mental health issues. It could look like obsessive compulsive disorder, Tourette's, anorexia, ADHD, sleep disturbances, urinary issues, dyslexia, dysgraphia, separation anxiety, and even suicidal behavior. Symptoms can vary from one child to the next, and they can also vary in their severity. A mild case, the child might be able to continue to participate in their normal activities without the outside observer being able to tell something's wrong. And in severe cases, it can become life-threatening. The children who do die from this disorder do so because they starve themselves to death or they commit suicide. The disorder has a relapsing, remitting course, so symptoms wax and wane with treatment and with exposure to infections. And if it goes untreated, symptoms get worse. Some children who develop PANS are misidentified as having autism spectrum disorder, and some children who are on the spectrum also have PANS and do not get treated for it because their symptoms overlap and it's considered just part of their autism. Our estimated incidence is anywhere from 1 in 150 to 1 in 200 children, which means, as Representative Bennett said, up to 20,000 children in Georgia. Most of them go undiagnosed and untreated. Treatment can be anything from a short course or a 30-day course of antibiotics and Motrin to longer-term antibiotics, multiple antibiotics, steroids, immune modulation with something called intravenous immune globulin, and then in advanced cases, even chemotherapy. Children also require psychological and psychiatric supports to manage the symptoms while the underlying cause is being resolved and the child's brain heals. Researchers do think that PANS has a genetic component, which is why we see families with more than one child diagnosed, which is the case in my family. I have 3 children who are affected. PANS does not have an ICD-10 code, but PANDAS, which is the streptococcus-triggered version, is included in the ICD-11 that will go into effect in January 2022. And the lack of a code complicates insurance billing and leads to a perception that it's not a real or accepted medical disorder, in spite of 30 years of evidence to the contrary. As of now, Georgia parents who seek help for their children who have these symptoms are unlikely to ever even hear of PANS, much less get treatment. SEPA's work here in Georgia over the last 2 years has dramatically increased parental, public, and provider awareness. But even as we've done that, there are still only a handful of providers in the state who treat. We have 3 practices that we refer parents to most frequently. 2 of them don't accept insurance at all, and a single visit can cost up to $1,500. If you do the math, 20,000 kids, a handful of providers, most if not all of them in Atlanta or the Atlanta area, the odds of getting appropriate treatment are slim in Atlanta, and they're virtually 0 outside of the city. As of right now, none of our major hospital systems, children's hospital systems in Georgia has a PANS or PANDAS clinic. Multidisciplinary clinics are being established all over the country, and having one here would be eminently logical given our state's incredible medical research and bioscience resources. In the 2 years that I've talked to families in Georgia about their experiences, I have not heard of a single child who's gone to an emergency room in Georgia and been appropriately worked up or treated, even if the parent asks for it and even if their child already has a diagnosis. This lack of awareness and access to appropriate medical care is unacceptable. Children's lives are at stake. When a family is lucky enough to get a timely, accurate diagnosis and treatment, it can quickly consume all of a family's resources, and you'll hear more about that from the other families here today. First-line treatments, the ones that we use when we have early diagnosis and treatment, antibiotics, Motrin, and steroids are very inexpensive. The second line of treatment, IVIG, is explicitly excluded from most Georgia insurance plans as experimental for PANDAS, in spite of significant research and overwhelming clinical support for its use. Treatment guidelines released in 2017 established that 4 to 7 rounds of IVIG is the standard of care for moderate cases. A single round of IVIG can cost more than $10,000 out of pocket, and I don't know very many families who can carry the burden of $40,000 to $70,000 a year for one part of a treatment plan in a single year out of pocket. The line of treatment for advanced cases, rituximab is the most commonly used chemo drug, which costs $60,000 per round. Most kids who receive this treatment need at least 4 rounds over 2 years plus monthly IVIG, bringing their out-of-pocket cost to $500,000 in 2 years. And that's a best-case scenario. And sadly, I do know families who have taken all of the equity out of their homes and drained their retirement accounts to pursue this treatment option to save their children's lives. One estimate is that about 5% of cases are severe, requiring these more advanced treatments, or about 650 kids in Georgia. These children have 0 treatment options in our state. If they get appropriate care, they most frequently get it at Texas Children's or Miami Children's, sometimes after being life-flighted out of our local children's hospitals. If they don't get treated, they risk permanent disability or death. Georgia children, those who are diagnosed, those who are misdiagnosed, and those who have not yet been diagnosed, need 4 things, and our families do as well. We need public awareness for parents, educators, and providers who don't know about these disorders, can't identify them, and don't treat kids. We need public health surveillance to understand how many children are affected. We need access to care, which means being able to go to our pediatricians, our subspecialists, and our hospitals as soon as we notice something is off. Get a full workup that follows the standard of care that was established in 2015, and start treatment immediately so our children never need the expensive, invasive, and life-altering therapies that I've discussed. And finally, we need insurance coverage. Our families cannot bear the cost of out-of-pocket treatment. We need the standard of care treatments to be covered by our insurers, whether we are using Medicaid or a private health insurance plan. This issue is complex and multifaceted, and as parents, while we've made a significant impact on awareness within the state, we need good public policy backing us up. We need a clear plan for using existing education, healthcare, and public health infrastructure to rapidly disseminate information and expand access to services. We need to ensure that affected children are getting their underlying medical issues treated instead of cycling through social and educational services that only contain their symptoms. And we need an insurance company for our families, insurance coverage for our families. Having a study committee would give legislators and subject matter experts the opportunity to better understand the various parts of this issue and discern how to craft good public policy that will improve outcomes for our children and families. Thank you for your time, for the considerable compassion that we've received from the legislators we've met with on this issue over the last 2 years, and most importantly, for your support. Okay. Thank you very much.
Thank you. Does anyone have a question for the presenter? Okay. Seeing none. Thank you, ma'am. I have one request. Let's keep our presentation down to 3 minutes or less, because we have another bill we have to address after we finish this one. Okay. And you are Heather Ward?
I am Heather Ward.
Very good, thank you.
My name is Heather Ward, and I am from Sonoy, Georgia. I am also a founding SEPA board member. My husband Scott and I have 3 children affected by PANS and PANDAS: Neely 14, Lucy 10, and William 6. Our oldest son, Neely, was diagnosed in September of 2013 at the age of 8 by the physician who handled his ADHD and mood medications. While having a discussion about why none of the many medications we had been trying over the past year were working, I mentioned in passing that he had been sick several times and that he didn't want to go to school. It was then that this forward-thinking physician put the pieces together and we heard the word PANDAS for the first time. He sent us for blood work, and we discovered that along with the 2 strep infections he had in the 4 months prior, he also had an acute mono infection. At that point, he was raging daily, had extreme school and separation anxiety, mood issues, sleep issues, tics, and more. By December, he was on stimulants, non-stimulants, antipsychotics, antidepressants, and incontinence meds. That doctor sent us to a PANDAS-friendly pediatrician, who in turn referred us to a PANDAS expert in Illinois, whose first-time consult fee was $500. $500 we didn't have readily available. In the meantime, we waited several months for an appointment with a neurologist at a local children's hospital. That appointment was fruitless as the physician spent less than 15 minutes with us. He told us that PANS and PANDAS did not exist and that our child had Tourette's, to start him on this new medicine and try not to let the tics bother us. During a rage in January of 2014, just months after his diagnosis, our son, age 8, threatened to murder himself with a kitchen knife. At that point, we made the decision to spend the first $16,000 of the $32,000 we would spend in a 9-month period to get 2 high-dose IVIG treatments for our son. Our children have suffered with OCD, tics, rage, sleep disturbance, anxiety, urinary issues, regression, and behavior in school. We have dealt with trying to jump out of a moving vehicle, not being able to leave our side, days of not sleeping, seizures, and losing years of their childhood. They deal with illness after illness, only to go through denial after denial, appeal after appeal, and denial again for treatment, not only for PANS and PANDAS, but for immune deficiency that was either caused by PANS and PANDAS or worsened because of not being able to get treatment. Our oldest son was suicidal at both age 8 and 12. He's been on hospital homebound twice. Our youngest son is now on hospital homebound after filing both a state and federal complaint because his 504 plan was violated. We are also currently awaiting word from a second appeal on the 4th insurance denial for IVIG over the last 2 years for our youngest son. Both our oldest son and daughter have had multiple denials for both IVIG and antibiotics over the past 5 years. We have suffered huge financial setbacks, including bankruptcy and almost losing our home. My husband and I both work full-time jobs. He is in law enforcement and takes on multiple extra jobs each week to help cover all the extra costs that we incur, from co-pays, blood work, therapy, medications, and more. Thankfully, my job allowed me to work from home and reduce my hours to be able to spend the time it takes to attend the numerous and time-consuming day-to-day tasks involved in caring for 3 children who are chronically ill. I can't begin to tell you the suffering all 3 of our children, our family, and the ways our own mental and physical health have suffered over the past 10 years in the 3 minutes I have here today. Our family life is in a state of crisis much of the time. However, over the last 6 years, I have encountered many children and family in much worse situations than ours. Parents who have had to feed their children through a syringe or standing with a parent in an IC unit after a child attempted suicide from living with the overwhelming struggles of OCD and the hell that is PANS and PANDAS. Our family, as well as thousands of families in Georgia, need immediate and long-term solutions for these children.
Thank you, ma'am. Let's see, Sonia McAvoy, okay.
My story is similar to Heather, so I'll try to keep it brief. But the main things I want to stress are we saw close to a dozen physicians and healthcare providers before we got an accurate diagnosis.
Can I interrupt a second?
Mm-hmm.
From what I've understood and talking to several, that there are 2 primary issues here. One is diagnosis by the physician, and then once diagnosis is determined, then treatment or covered
Yes.
treatment.
Mm-hmm.
So just to give you a heads up, like I mentioned, there's the 2 primary issues. Number 1 is diagnosis, because a lot of physicians may have never come in contact with this particular issue, and even those who have, all these children are different, because for those of you who don't know, I'm learning a lot about this. Most children, while they're in school and young and all, will get strep throat about 3 times a year. Now, some of it is severe, some of it is mild, but 3 times a year from what I understand, the average child gets strep throat. So go ahead, I'm sorry.
No, thank you, that's helpful. And another factor for my child was, as Jessica had mentioned, some children don't present symptoms of strep at all.
Into the microphone.
Sorry, some children don't present symptoms of strep at all, as in they don't have a sore throat or a tummy ache, which most children would present with. So unless you are aware that this medical condition can cause neuropsychiatric symptoms, it would never occur to you to check for strep. So my daughter had multiple strep infections that were not diagnosed or treated, which caused the illness to escalate. And we received multiple misdiagnoses from multiple specialists that we paid for out of pocket. We were lucky to also have a friend who had had this illness, so she encouraged me to keep seeking other doctors. But for the many families out there, we followed all the steps that we felt we should, but still did not get appropriate diagnosis or treatment. So I'm sure there are an untold number of children who are suffering, who are not getting appropriate care. We were told our daughter would need to go to a behavioral school. We were told she had bipolar and she was given antipsychotics. Now she has had IVIG and she's a completely different person. And I have to think she would likely be in an institution at this point if we had not received that care. So thank you very much. I'm happy to answer any questions.
Oh, we got one. Chairman Hatchett.
So does the treatment that you receive, does it cure it, or does it just give you a reprieve of the symptoms, or how does it?
I think that's hard to know at this point, so I don't want to answer definitively.
Okay.
For my daughter, she requires a monthly infusion of IG at this point. I do feel if we had caught it earlier, that would probably not be the case. Some children are able to receive treatment right away and can be years or never again need such treatment.
Okay, thank you, ma'am. That's the last question. All right, Nicole Colwell.
Hello, I'm Nicole Caldwell, and I live in LJ, Georgia. I have 4 children. Lila is my daughter, who is affected by PANS in 2016. With our case, it was a little different than theirs. Overnight, she changed pretty much. At first, I thought that she had been touched inappropriately, is how different she was. I couldn't figure out what was going on. We went to our normal PCP, we went to CHOA, we went to numerous avenues, we went so many different places. They all led us back to psychiatric care. Go see a psychologist, go see, when you go there, go here, go get counseling. So we went down that avenue. We basically wasted a lot of time. When in my heart, I knew my daughter can't have a psychiatric breakdown overnight. She was 8.5 years old at the time, straight A student, active in sports, just a typical, beautiful, growing girl. We went down the pig trail they sent us on everywhere. During that time, my ex-husband said that I had Munchausen by proxy and called an emergency hearing. So I want to paint the picture of how not only does this affect us financially, but it affects every aspect of our family. Because then I was struggling to keep my daughter because they were saying that I was causing this psychiatric illness. After we went through therapy, they sent us to a telecom interview with a psychologist and he was in Georgia, but he ended up telling me that if I was refusing psychiatric care and treatment and drugs, then they would take my parental rights and she would be institutionalized. With tears in my eyes, begging them, they gave me 1 week to prove something medical was wrong with her. And I was shooting in the dark. I had never heard of pandas or PANS. I just knew through prayer and my gut feeling that there's got to be something going on with my daughter. You can't give me a list of bipolar, OCD, ADHD, all of this stuff overnight. And she was having motor tics, vocal tics. Her eyes were going like that. That doesn't happen to a beautifully growing little girl. So during that week, I was able to take her to a mother who was a nurse practitioner, and I begged her, test my daughter. We tested for everything under the sun, down to AIDS virus. It came back with a slew of infections. She had staph infection, Lyme, Bartonella, Babesia, Mycoplasma pneumonia. I could keep going. So I told them, I said, can an infection affect the brain? And that's when I got on YouTube, and I found a mom in another state, and she was telling the story of her son, and she saved my daughter's life. After watching that video, I went back to the doctors, went to CHOA, went to an infectious disease doctor, specialist at CHOA, and another one in Canton. We saw it was 51 appointments through different specialists and doctors, 51. That while my daughter was struggling, while I was dealing with court system to keep my rights, while my other 3 children were being raised by other people. So our whole family, I'm still in the battle legally because it's all just going through the court system 2 years later. Today, this is Lila, and yesterday she was asked to be in the Junior Beta Club. She is growing beautifully because we were able to, in March is when I noticed the first onset. July is when I learned about pandas and pans. This is in 2016. November is when I found a specialist and when my rights were about to be taken. December, we started antibiotics. And during this time, I had to move to a cabin away from my family to isolate her. I made her her own little psych ward, and I cared for her for 24 hours a day so she wouldn't harm herself, or she was scared to death of weather. So if you can imagine walking outside and seeing your mom's hair blow and think a tornado is going to come. That's the world she lived in. If the sky was blue, one white cloud would send her into a panic. So we lived in this cabin with sheets covering the windows. Treatment started in December, and by March, just antibiotics and supplements. She woke up and said, "Mom, can we go home?" And we had reset her little system, and all of the infections were starting to go down. So as the infections went down, all of her symptoms went down. From that, I swore that I would raise my voice for all of the other mothers, and you're about to hear from a mom who, because of Lila's story, it saved her son. She's from my town too, and I won't take her story, but the awareness part of this, aside from the financial burden and us having to travel out of state for treatment, my daughter, if I had listened to specialists, she would be in an institute because psychiatric meds would not have helped her. And these kids are our future. So if they're locked up for something that's preventable and treatable, we suffered for 2 years, and she's doing great now. But there's a lot of families that go on for years. So early detection and just the doctor's knowledge and awareness is crucial.
You want to speak? Push that button. You have a question, please?
Thank you, and I appreciate the difficulty of this, the early diagnosis. I've gotten some information on this as I also sit on Health and Human Services, and I'm sorry we have to kind of keep looking, but medicine sometimes isn't an exact science. But is there a single test that can be given? The answer is no, I think.
And
so that's why
panel.
And the only I say that I'm a little defensive for our friends in the medical community. There needs to be greater education on what to look for. But if there's not a single test, it is going to be one of those that you go through almost a trial and error process. And I know you don't want to speak as ugly as it sounds sometimes to the medical community. They certainly need how to look for it sooner. Mm-hmm. But if there's not a single test, you can't sit there and just do a swab and go, "Oh, you've got this." I just want to make sure the members of the committee know that. It is a tough one to diagnose, is it not?
It is.
So I want to give the doctors a little benefit of the doubt here. Thank you.
It is, and if I can add, your biggest ticket when it comes to diagnosing this is the mothers. A mama knows when her kid is not okay. And I think that when the doctors will actually listen to the mother, the mama's always right. Every one of y'all in here have a mama, and mamas are always right. So
always right.
Usually. So thank you for your time.
Thank you, ma'am. Okay, Stacy.
Thank you. My name is Stacy Brill. I was born and raised here in the metro Atlanta area. My husband and I live in Sandy Springs. We have 2 children, Ryan and Olivia. When our daughter Olivia was about 3.5, we noticed her exhibiting some new and strange behaviors, and we suspected she might have Tourette syndrome. We took her to see a neurologist here in town who told us that her verbal and physical tics were waxing and waning and cautioned us not to call attention to them for fear that Olivia would become self-conscious of her differences. As young parents, we took the advice of the experienced physician and shrugged it off. It took us about 6 more months after Olivia had developed some concerning obsessive and compulsive behaviors that we decided to consult with another doctor, this time a psychiatrist. At this point, our 4-year-old preschooler was counting and tapping everything she contacted. She couldn't put on a t-shirt, a pair of pants, or her gymnastics leotard without counting and recounting in even numbers until it felt just right to her. She would touch the sidewalk, bus tires, garbage cans as we passed them by, not in an exploratory way as young children do, but she had to, and always an even number of times. The psychiatrist labeled our preschooler as a child with obsessive compulsive disorder, OCD. Having been potty trained for a couple of years, our 4-year-old began having accidents. She felt ashamed and disappointed in herself, and we were confused. Her sleep became erratic, she was exhausted, and so were we. By the time she reached her kindergarten year, she was the only child in her class taking full advantage of the allotted rest time at school and would fall asleep after school as well. In November of her kindergarten year, her OCD and tics were officially in her way. She couldn't get through more than 3 words without verbal and facial tics. She developed Sydenham's chorea, which is a rapid, uncoordinated jerking movement in her arm, and it took us a tremendous amount of time to walk down a hallway. She was a mess. We all were. This was not waxing and waning tics. This was not OCD, and it wasn't just both. Through online research, we found the term PANDAS, pediatric autoimmune neurological disorder associated with strep. We looked at her medical records and realized that she had had a strep infection just before the initial onset at 3. Was this our answer? Fortunately, our family is able to pay out of pocket for the battery of testing we needed to have done to determine a diagnosis for Olivia. We also had the resources and the freedom to see the practitioner that we were referred to in DC. We called her office in Washington, DC every day for 2 months, hoping for an opening in her schedule. Olivia was very weak and sluggish during our initial visit with Dr. Elizabeth Latimer. She had lost her twinkle and her bubbly personality. We were scared, but also hopeful that Dr. Latimer would put us on a path to recovering our little one, that she would again be able to enjoy playing in the park and eating food and interacting with people and everyday items in appropriate ways to grow and thrive. After confirming Olivia's diagnosis of PANDAS, Dr. Latimer prescribed a round of steroids, round-the-clock Motrin, and an antibiotic. She suspected that since Olivia's case was mild, and we thought, mild? That she would not require additional interventions like IVIG or more aggressive treatments like rituximab. Within a week, our 5-year-old was noticeably better. Her tics and Sydenham's chorea were diminishing, and we were amazed and beyond grateful for the intervention of modern medicine. Olivia will be 9 in 2 weeks. She is still on twice-daily doses of antibiotic, and we monitor her immune system closely. Although we have not completely closed the gap on her symptoms, she leads a normal life. I remember crying the first time she put her leotard on without counting. That was 2 years ago. I remember the day she left her room without closing the door and turning the knob 4 times. My husband and I quietly give thanks each time we notice her progress and are hopeful that with each setback exposure to strep in a classroom or on an airplane or at camp, that we can regain lost ground. We are among some of the luckiest, most blessed in the PANDAS community. Our hearts feel the pain of the families whose lives are devastated by cases that are stronger than Livy's. Our family committed financial support to educate physicians in the Southeast, specifically pediatricians, so that they can identify symptoms of PANS and PANDAS, know what tests to order, and how to intervene. How many months could we have recovered if the first doctor we saw had considered PANDAS and didn't just write us off with waxing and waning tics? Thank you for your time, attention, and interest. We are all hopeful that the PANDAS community can count on your strength and support as we battle on.
Well, I see no questions. Thank you, ma'am. I tell you, the pain affecting your children is probably one of the most painful pains you'll have, whether it's your children or grandchildren or whatever. And to go from a healthy child to, like one of the presenters said, just overnight, can be devastating to you as a family, and also you as for your child. Representative Perkle has found something that probably needs to be corrected in the bill. You're number one, so.
Well, thank you, sir. That is very kind of you. Mr. Chairman, if it please, I would like to make an amendment to this on line 16. If we could have this line read, whereas PANS and PANDAS affect a small subpopulation of patients, and then strike with PANS and PANDAS. So strike those 4 words from line 16 at the beginning of 17.
It's just redundant language.
It is
It's scribbler's
redundant
error.
language. Yes,
Okay.
sir.
We have a motion to, okay.
Parliamentary inquiry,
Yes, sir.
should we not take a motion to accept the resolution, the 4 amendments?
I'd rather do amendment, approve amendment, and then we'll do the resolution as amended.
Okay.
Okay?
I have a second, but.
Okay,
would you
well,
rather-
let's do this one first.
Okay.
We'll strike those 4 words. Do I hear a motion to approve? Second?
Second.
All in favor, say aye.
Aye.
Okay, your second recommendation?
Is on line 112. The general way that House study committees work is that December 1st is generally the abolishment date, and I would suggest on line 112, the committee shall stand abolished on December 1, 2019, to be consistent with the other study committees that we have and allow time for, if legislation needs to be drafted going forward, that there's some time. So I suggest taking December 30 and instead including December 1, 2019.
Okay, so all you'll do is change that one number from 30 to 1.
Yes, sir.
Do I hear a motion? All right, do I hear a second? All in favor say aye.
Aye.
Motion carried. We have House Resolution 590 as amended. Do I hear a motion?
So moved.
So moved, do pass. And a second? All in favor say aye. Thank you. Best of luck on your study committee, and I wish you a real success on this. Were you here to speak? Oh, I'm sorry, you wasn't on my list.
I'm Tiffany Watson. Mine is actually short and sweet, and it's more of a success story, just to wrap things up.
Okay.
Do you have time? I'll be very brief.
You got a couple of minutes, yes, ma'am.
Okay. So my name's Tiffany Watson. My son is Lucas Watson. I'm from LJ, Georgia, and Nicole, she was a few speakers before me. My son had multiple infections, strep, flu, and he had the cold sore virus that got in his eyes. A couple weeks later, I had not connected the two, but he developed OCD behavior. He could not step on cracks. Just like you heard from many of the mothers, overnight his life was changed. Thanks to awareness, which I know is a big part of this, Nicole Caldwell, just through social media, I had been aware that there was a connection between infections and children, everything changing. So I contacted Nicole. My husband at the time did want to go to Children's Healthcare of Atlanta, different places to make sure there wasn't anything psychiatric going on. We did a spinal tap and all of, everything that medically they thought, needed to be done. It wasn't until I went to our primary care physician in our small little town that he was willing to listen to me. And he had an intern from Emory come in, and he had heard of PANS before. So Nicole he wasn't sure what testing. You had asked if there was any kind of testing or blood work. There are some markers you can test for to see if they have strep in their system. They did that, and within weeks, we got those tests back, and they were able to start treatment just with antibiotics and Motrin, and my son just turned around within weeks. So we did not have to suffer like these other mothers and these other families have because of early detection and a doctor who would listen. So we're very blessed and we're very grateful, and I'm just here to give a success story on my family and my son's behalf.
Well, very good. Thank you, ma'am. All of you will have the opportunity during the study committees to make your presentations again. Representative Bennett, your resolution has passed. So y'all can get the committee appointed and get started. Thank you. Okay, thank you, ma'am. You'll see House Resolution 584. Representative Jones. This study committee, our proposal is to create a study committee on exploring a floor and trade charity care system. It's all yours.
Thank you, Chairman Smith. Committee, I come to you today to talk about floor and trade. I've had the opportunity to speak to many of you kind of on one-on-one conversations and on some of you during a previous committee meeting. I thought what I would do is very quickly, before I jumped into the PowerPoint, I think the PowerPoint is necessary just because it gives context to what it is that we're trying to accomplish within the study committee. As I had the opportunity to sit with you on the committee that we're currently on, the thing that we kept talking about, well, not kept talking about, but one of the areas that we were trying to address was indigent and charitable care. And when we were looking at the language as it exists today and some of the different bills that we were able to review, one of the things we saw was the idea that we would, as the state of Georgia, put a mandate down to all of the different stakeholders in terms of what they would need to do in terms of indigent and charitable care. So I thought that maybe there was a possibility that there's another way to do that. Doesn't mean that was wrong. It just means, is there an alternative for us to consider? And I started to look back in terms of what I did back in the 2000s in cap and trade. And I know cap and trade sometimes has a negative connotation, but in this case, cap and trade has a really positive connotation. Because if you think about how acid rain was addressed in the 70s in New York, Mid-Atlantic, New Jersey, etc., it was through cap and trade. It was not a mandate, but rather it was telling the stakeholders, we believe more in you than we believe in the government, and we have a socioeconomic problem that we need to solve. And that problem was we needed to get rid of cap and trade. So the idea that I kept thinking about was not get rid of acid rain. So I kept saying to myself, how is it that we could get the stakeholders, that's the hospitals, the medical centers, the physicians, the insurance companies, you name it, how could we get them motivated to want to be able to do what we all know to be the right thing, the moral thing in terms of providing indigent and charitable care? So the idea came to me, which was floor and trade. So if you can just humor me just for a moment, I know rules is coming in here very shortly, so we have a very constrained time frame, but I think it's important enough to kind of go through this because what we're talking about is something that we know we have to address in Georgia. And we're doing a lot right now with the Patient First Act and so many other things, but I think this is a mechanism to drive three key things. One, innovation, and we don't see enough of that. Two, greater efficiencies, and three, greater capital flow, especially into the rural areas of our state. And if you humor me for a couple minutes, I think I can show you the path to there and what it is that we'd like to do within the study committee. So if you go to the first slide, it's around what cap and trade is in terms of, let me just give you a quick primer, because everyone that I had the opportunity to speak with, people have heard about it, but they don't necessarily know it. So very quickly, the whole idea is within cap and trade, and we'll take acid rain. What they were trying to do is reduce two things. One, nitrogen, and two, sulfuric acid. Turns out you put those two together and you slap some rain on it, it gets acidic. So what they wanted to do is cap the amount of what they called SOx and NOx into the atmosphere. But the whole idea is the government came in and said the cap in the first year will be X, and we have a goal that over the next 10 or 20 years, the cap will, and you see it here, will slowly but surely go into a downward slope. Now, what did that cause? If you can imagine each of you, and I don't want to break any house rules by saying names, but if each of you were your own company emitting into the environment, and each of you were told that you are capped at 10, let's just say 10 tons of SOx and NOx, and if suddenly half of you were emitting 9 and the other half of you were emitting 11, the ones that were emitting 11 need a little help because you're over the 10. So you'd go to the ones with the 9 and do what? Make a deal. Can I buy that 1 ton from you so that we'll both be at 10 as opposed to me at 11 and you at 9? So slowly but surely what started to happen was you started to get some innovation. Instead of the smokestacks just triggering up, they basically started to have cleaners and buffers and things like that. All kinds of new R&D started to come into this. The second thing it started to do was efficiency, because those that were able to go underneath the cap, what did they do? They wanted to make more money on every ton they were selling, so they got more efficient. And then finally, capital flow. Those that just couldn't figure out a way to get it right, what did they start to do? They started to invest money in those who could. So let me give you the parallel on the next slide. If we could imagine a floor and trade system, imagine a floor of charitable and indigent care. Our role is limited to really 3 things in this model, at least as I'm going into this. I want the committee to help over the summer. But the idea would be we create a floor. And let's say it's 10%, just again for easy math. I'm in Forsyth County. I think many of you know, Forsyth County, we're not going to be able to reach that 10% most likely. But there are rural hospitals I've spoken with, Grady I've spoken with. I can assure you, they're over the 10. So suddenly, a Forsyth County hospital, maybe a Buckhead hospital, and others are looking out to those rural hospitals for what? For help. In the beginning, it's can I buy a credit from you? Maybe later on, it's can I invest in you? Because you know what? You figured out a way to do great with indigent and charitable care. I bet you if I put 10 million, 20 million into your hospital, you'll get better equipment, do it more efficiently. Now suddenly we have capital flow into the rural hospitals. You see, this is all about trusting the stakeholders, and it's about us basically providing the guardrails, which then leads to the next slide. The idea would be, if you can, the first 2 years we'd like to create, and again, this is subject to the study committee, but the going in idea is the first 2 years would be bilateral contracts. So that's between me and Representative Perkle, or me and Representative Fry. But ultimately, the goal would be to have this on an exchange. Think about pork bellies, think about orange juice futures. In this case, call them an ICU, an indigent care unit. What we would want to do as the government is really only do 3 things. 1, set the floor. 2, we want to review the audit reports. Not because we don't trust the Cordial medical system, but we want to look at what their auditors said in terms of the amount of charitable and indigent care they gave and make sure that's the case. 3, we want to make sure when the market starts, we don't have any unusual activity. Think of the SEC. Think of long positions, short positions. If we see something just a little bit unnatural, we want to be able to go in there and make sure no one has any insider information, no different than any other market that we have here in the United States. So the idea would be, I'm Forsyth County, and Clay, if you don't mind, or Representative Perkle, I'm going to buy from him, but I'm not going to send my money directly to Representative Perkle. I'm going to send it to the Indigent Care Trust Fund. Why? That ensures our match. We need that match on the Medicaid side. Second, we would want to be able to use that trust fund as basically a depository. If we can remember the time when we were on the gold standard, the amount of currency that was out was basically equal to the amount of gold inside the Fed Reserve. Well, think about, we would only have the number of ICUs, remember, indigent care units out, that are equal to the amount of money that sits in the trust fund. This ensures the market never goes out of balance. But it does allow Representative Perkle's Medical Center to cash in your ICUs to the trust fund and be paid X millions of dollars for them, and it allows me, say from Forsyth, to be able to pay into that. So ultimately, that is what we would like to be able to study. And I wish I was smart enough. I wish I had the knowledge of everything, I'll say medical, when it comes to financing and all the different things that make up Medicare and Medicaid, but I don't. And I think this study committee would allow us to be able to put the meat on the bones that we would need in order to make this successful. I'll stand for any questions, Chairman Smith.
Okay, Representative Perkle.
Representative Jones, I must tell you, that outside of the box thinking is the most refreshing thing I've seen in a while, and you and I have talked about it, and I'm still excited about it. I can understand the one side of the picture for where I'm from, we have way more than 10% indigent care, way far beyond it. What happens if a covered medical facility does not meet the floor?
Well, I think our going in position, and I should have mentioned that, and thank you very much for asking it. One of the things we did in the 2000s was we realized we couldn't just let the wealthy be able to just pay their way out of it. So what we did was for each ton that you were short, there was a penalty plus the cost of abatement. So that meant there was a penalty of, say, 100 euros, and the cost of abatement, we knew what the cost of abatement was because the market was telling us that each one of the tons was worth, say, $10,000. So you were paying 100 euros or 200 euros or 500 euros plus the cost of abatement. This then basically causes, I'll say, the wealthy to be able to say, you know what, I can't just buy my way out of this. I have to innovate my way out of it, I got to get efficient, or I need to move capital into the areas that do go above the floor so that they are able to help me. Thank you for the question.
Okay, I don't see any more questions for the gentleman. Sound like an interesting concept, especially within the Care Trust Fund. We have one individual. Where'd Ethan James go? You still want to speak, or just let me say that you're in favor of this? Georgia Hospital, Georgia Hospital Association is in favor of. Okay. With that being said, we have a motion to do pass. I have a second. All in favor say aye. Very good. Thank y'all. I think that may be our last meeting for this session. Y'all have a great day, hopefully.